Good evening, everyone, and thank you for joining us for tonight's Woo You event. Today we have with us again Dr. Mitch Ibach, and he is going to be talking on Perimetry Primer, Fundamentals of Visual Fields. I'll be your host tonight. My name is Dr. Ariel Sorenzi. So it's my pleasure to introduce our speaker tonight, Dr. Mitch Ibach. He is a residency-trained optometrist at Vance Thompson Vision in Sioux Falls, South Dakota. He attended Pacific University College of Optometry, where he graduated summa cum laude. Mitch completed his residency training at Minnesota Eye Consultants with a concentration on cornea, refractive surgery, external disease, and glaucoma. One of these is not like the other. Like front of the eye, back of the eye. So he joined Vance Thompson Vision in 2014 to focus on advanced anterior segment surgery care and pathology. He is a fellow of the American Academy of Optometry, an Intrepid Eye Society member, a board member for the International Keratoconus Academy, a member of the AOA, the Optometric Glaucoma Society, and the South Dakota Optometric Society. He's also the residency co-coordinator at Vance Thompson Vision. So we're so excited to hear from you tonight, and thank you for sharing all of your expertise with us.
Awesome. Thanks, Dr. Sorenzi, for that warm introduction. Here are my financial disclosures. All financial relationships have been mitigated. And so, good evening, everyone. Thanks for joining. Hopefully, some of you have a visual field in your practice, but you're maybe underutilizing it. You're unsure when to order the test, or maybe how to interpret the results, what you're seeing on the printouts. Or maybe you're here tonight because you're hoping to add perimetry, add visual field to your practice, and you want to talk about some of the nuts and bolts, the foundational pieces of perimetry. Either way, you've logged in to the right spot. We're going to start with some definitions on visual fields. We'll move into different pathologies that visual fields aid us in. And then we'll spend the majority, the meat of our time tonight, really talking about visual fields in glaucoma. And so we're going to start with really 1,000-foot view. We're zoomed way out here. Simply, what is a visual field? Well, physiologically, your visual field is everything visible at a single time point in one eye. The key is visual fields are monocular. And so we can demonstrate this. If you take up your left hand and cover your left eye, look directly at the middle of your screen or monitor, everything you can see from that fixation point is your visual field. Performing a visual field allows examiners to identify field loss in a specific location. What is the normal visual field? This picture on the right is courtesy of the Field Analyzer Primer. This is an ebook, 5th edition, courtesy of Zeiss, and this is really a great PDF resource. It's a free download to grab so that you can dig into visual fields. You'll see a lot of pictures from this tonight. It's really a great resource. And so with our normal field of vision, from a fixation point superior, we have over 90 degrees of visual field, over 90 degrees temporal visual field, 60 degrees superior. Nasal, we have 60 degrees, we're blocked by our nose. And then inferior, we have about 70 degrees of visual field, again, relative to that fixation point. It's important to remember, though, in the normal visual field, we expect to see a physiologic blind spot. Everyone has one. The physiologic blind spot is an absolute scotoma, meaning total darkness. We compare this to a relative or partial scotoma where there's reduced sensitivity to light. But our physiologic blind spot, this absolute darkness or blind spot, and the reason that we have this is because it's the location of where the optic nerve enters the back part of the eye in the retina. The optic nerve lacks photoreceptors, and so the optic nerve enters the back of the eye about 15 degrees nasal, and so this results in a blind spot that's located 15 degrees temporal to the fixation point, and the average blind spot on visual field is commonly about 7.5 degrees. And so you can see that right here, again, 7.5 degrees. We see it being temporal on this visual field. Let's review 3 common visual fields that we do in practice. First, you have an Amsler grid. This is a suprathreshold test. A patient can either see it or they can't. It is not a relative test. We're not looking for partial scotomas here. And with Amsler grids, we're really testing macular and ganglion cell function. Of course, we all know that most commonly we're using this for some type of foveal or macular pathology, looking for distortion, and it's really looking at the central 10 degrees. Next, you have confrontation visual fields. This is really thought of as a screening test here. It's usually done maybe by one of your technicians, or maybe you do it in your practice, but it's really hard to get a classic grading on this because it's a gross visual field or confrontation visual field test. And then we have perimetry. In perimetry, we have both automated and manual visual fields. You can see commonly testing 20 degrees, 48 degrees, 60 degrees. We can have these in a tabletop version. We can have in headset version. And then we also have our manual visual fields, which is like a tangent screen where we're moving the object for the patient. And so that's a nice segue into defining kinetic versus static perimetry. And so if you look at the two top pictures here, kinetic perimetry is where the test object is moved, but the brightness and size are fixed. And so this is Goldman perimetry. This is a tangent screen. And then on the bottom, we have static perimetry. With static perimetry, the test object is fixed. We're not changing, but the brightness and size are varied. And this is your Humphrey field analyzer, your octopus visual field, your headset visual fields, and others. Standard automated perimetry, or SAP. This is a term to note. This is the type of visual field that we're most commonly doing in our practice, where the clinic goal is to quantify the sensitivity of a patient's peripheral vision. And so this is a threshold test. It's kind of that stair-step approach where we're trying to grade a patient's sensitivity to a visual stimuli. So this is not all or none. There are standardized testing algorithms. It's quantifiable with, again, this kind of stair-step grading system. We're measuring 30 degrees or usually less from any fixation point in any direction. And so to the right, you can see a tabletop visual field. Many of us are very familiar with this. This is your Humphrey field analyzer. To the right of that, you see a headset virtual reality visual field. And so now we've covered some of the terminology with visual fields. Again, we're going to zoom back out and just simply answer, why do we have patients perform visual fields in our practice? Well, I think it's two reasons. Number one, we want to detect and diagnose visual field abnormalities. This is the initial test, the detection and diagnosis of visual field abnormalities. And then we're going to do serial visual fields over time to look for progression of visual field abnormalities. For conditions that may require a visual field, it's really the big three. And so we'll talk about three main conditions that visual fields can aid us in. First, we have neurologic diseases. That's the picture of visual fields that you see on your far left. The key to remember with neurologic visual field loss is in the visual pathway. Once we get to the optic chiasm and posterior in the visual pathway, now we're talking about bilateral visual field defects, both right eye and left eye. In the middle, we have retinal diseases, just the opposite. Retinal diseases are most commonly going to be monocular visual field defects, and there's really no characteristic pattern with a lot of our retinal visual field defects. They tend not to respect either the vertical or the horizontal midline. And then on the far right, you have glaucoma. This is going to be our major focus for tonight, visual fields for glaucoma. And glaucoma results in characteristic visual field loss. It has a very patterned visual field loss. It corresponds to where the damage is on the optic nerve, the retinal nerve fiber layer, the ganglion cells. And visual fields for glaucoma tend to respect the horizontal midline more. And so let's look at some neurologic visual field loss. To understand neurologic visual field defects, it's really important to have a good foundational understanding of the visual pathway. If you're starting to become sweaty, if your skin is crawling, this is because it's difficult stuff. This is neuroanatomy in optometry school. There's a heavy portion of our boards tests on this. And so let's try to simplify a couple key pieces here. First, number one, if we look at the very top of the picture to your right, remember that in blue, on the left eye, the temporal fibers are going to say temporal, and the nasal fibers are going to cross. And so if we have a total cut at point A, the optic nerve, we're going to have total blindness in this left eye. But remember, temporal fibers stay temporal, nasal fibers are going to cross. Number two, the optic chiasm, picture or point B and posterior, is going to result in bilateral visual field defects. If we have a cut or a defect at point B, this is where we're commonly thinking a bitemporal hemianopia. We learn over and over that this is a pituitary tumor, but there's many other things that could cause this. But if the lesion or damage is at the optic chiasm, you see the picture of the corresponding visual field loss. And then number three, as we get more posterior in the visual pathway, the visual field defects are going to become more congruent. They're a more matching visual field defect. And again, it's going to be bilateral. And so let's play a game. Where is the cut or damage for this patient? You see these visual fields in your practice tomorrow. Is this an optic chiasm, pituitary abnormality? Is this a pre-chiasmal visual field defect, like a bilateral optic nerve defect? Is this a right optic radiation stroke, or is this a left occipital lobe? And so many of you are just in a room alone, so you have to yell out the answer and no one's going to hear it. You can have some bravery here. And so if we're working through this, I would say that this is a superior right quadranopsia. It has a high congruency, so we know we're posterior to the optic chiasm. We know that we're farther posterior in the visual pathway. And then if you're trying to determine, is this a right-sided or left-sided lesion or defect, use the eye that has the nasal visual field defect. And so this patient had a left occipital lobe stroke. If we're going to retina visual field loss, remember this is pre-chiasmal damage or lesions, and so we're going to most commonly see monocular visual field loss. Again, retina visual field loss usually doesn't respect a pattern for the superior or the vertical and horizontal midline, and so you're not going to see these matching defects like we do in glaucoma. And retina visual field loss tends to be more central visual field loss. So retinal damage results in more central visual field loss. And if we use this picture to the right, encircled is where you see 60 to 70% of the optic nerve fibers in this papillomacular bundle, kind of perimacular region. This composes that region, and in the retinal nerve fiber layer, axons that go to this area, they have larger, more easily identified axons for some of our pictures like OCT. And so hopefully this makes sense why we're seeing more central visual field defects for these patients. And then glaucoma visual field loss, the third of our big three. This is where we're going to spend most of our time tonight. If we start just foundationally at the definition of glaucoma, remember that glaucoma is defined as a progressive optic neuropathy that causes damage to the optic nerve or cupping and characteristic visual field loss. Visual field loss is in the definition of glaucoma. Perimetry is the number one way to assess the visual field. And then the number one goal of us doctors treating patients with glaucoma should really be preserving visual field. This is what patients care about. They maybe don't know that they care so much about their visual field. They come in with a little notepad that they write down every single eye pressure that you've ever measured. But really, ultimately, our guiding compass should be the visual field. And you can make the argument for OCT as well, but ultimately visual field is what we're preserving because that's going to lead ultimately to visual acuity. And so if we're just zeroing in on threshold visual fields for glaucoma, these are the most common degrees of measurement here. On the far left, we see a 30-2 test. This is measuring 30 degrees in each direction from a fixation point, 76 test points with 6 degrees of spacing. 30-2s are most commonly what I'm going to use in my practice for neurologic visual field suspected loss, but we're using these much less now in glaucoma because of a 24-2. 24-2 is 24 to 30 degrees of measurement degrees from fixation, 54 test points, with 6 degrees of spacing. This is by far now the most commonly used visual field in glaucoma. And then a 10-2 test, 10 degrees from fixation in any direction, 68 test points, and you can see much smaller separation in between these test points, just 2 degrees of spacing. This is really narrowing in on central visual field or macular function. The most common stimulus size with a Humphrey field analyzer is going to be 0.43 degrees. And so that helps to kind of give us some characteristics of 2-degree spacing versus what just the stimulus size is. I think a tried and true rule in visual fields is if fast is good, faster is better. Very rarely, if ever, if I had a patient who came in saying, "Doc, I'm really hoping to do a visual field today. This is a very important test, but a shorter test tends to be more reliable. Longer tests lead to inaccuracy and patient fatigue." And so specifically for Humphrey field analyzer, they have the SIDA algorithm. This is the Swedish interactive threshold algorithm. SIDA standard and SIDA fast was developed in the 90s, and now we have SIDA faster. And so for SIDA standard, you can see test range kind of mean there is maybe 6 minutes and 15 seconds. For a SIDA fast, we're hoping to get right at about the 4-minute mark. And now SIDA faster, sometimes under 3 minutes on average per eye. On the right, you see one of our headset virtual reality visual fields. This is a wearable device. It takes about 3.5 minutes here. And so I think a general rule is we need to have a benchmark of 5 minutes or less per eye for a visual field. We want these to be quicker and quicker tests. This is published in Ophthalmology in 2019, comparing algorithms for the SIDA platform. The take home really is the points differ just slightly between a SIDA fast and a SIDA standard, and a SIDA faster and a SIDA standard, but SIDA fast and SIDA faster are really, really similar to each other. If we're talking about SIDA faster, this is 30% shorter than SIDA fast and over 50% shorter than SIDA standard. And so the point really is you will likely get a more accurate test if it's shorter. You may lose a couple testing points from what you had with SIDA standard, but in my opinion, it's worth losing a few data points for better accuracy for our patients. And so here's really a great overview cheat sheet. We're going to move into now analyzing threshold visual fields. Again, this is from our HFA primer. You can see the source on the bottom there, but really a great ebook to become familiar with as you're either reviewing or becoming familiar with visual fields. This printout that you're going to see to the right, the printout that we'll use for probably the next 5 or 6 slides, is from the Humphrey field analyzer. But the good news is, depending on what technology you have in your practice, or maybe you're getting in your practice, almost all of our visual fields have a pretty analogous, pretty similar printout. A lot of them are using the same terminology, and so it's not exactly the same, but you're going to see a lot of the same values and maps. And so again, this is the HFA map, but it's very synonymous to many of our others. And so as I'm looking at a visual field, I start at the top. I know that this is a central 24-2 test. This is a SIDA faster. We have the patient's MRX put in. We have to account for accommodation with that. We see the test duration there as well. And we know that this is a patient's left eye visual field. And so whenever I'm analyzing a visual field, I'm always going to start in the top left, looking at the reliability indices. Is this a test that we can gain value from, or is this just really garbage in, garbage out? And so 3 real keys for reliability indices. First, you have fixation losses. What many of these tests do, these diagnostic devices, is that they plot the blind spot. And so they plot where the patient should have a total scotoma. And then during the test, it will present a light stimuli within the blind spot. And if a patient clicks, we know that that patient's looking around. They're not staying on fixation. That's a fixation loss. This is a poor fixator. And so I remember what the book will tell us, or what I learned in school, is we want to have under 30% fixation losses, or we should restart the test. Now, unfortunately, that is not always realistic in practice. And so as I'm having a patient 6 minutes into a visual field, I'm not going to restart that, because the patient probably won't do better on the second one, but also it's just very time consuming to do that. And so we're just urging them while they're taking the test to make sure we're staying on fixation. False positive our second reliability indice. This is your happy clicker. This is the patient that is clicking more than light stimuli are being presented. And this is my biggest concern of the 3 reliability indices, because if a patient is clicking too much, inevitably they will hit some of those spots, and we can underestimate visual field severity. We can also overlook a progressing visual field because of high false positives. And so I really want this to be less than 15%, or I'm starting to lose reliability and accuracy for the visual field here. And then finally, false negatives. This is your patient who becomes bored or falls asleep. The way that these tests get false negatives is they will present easier, more bright stimuli in certain spots. And then as the test goes on, they'll present a harder one. The patient gets the harder ones, the harder light stimuli, but they're not getting the easier, brighter stimuli. And so this patient becomes fatigued or bored during the test. And this false negatives you can have flagged or can be high in patients with severe disease because there's just a lower threshold for them to catch them. So we're trying to keep this below 20%. And so now that we have a reliable test, we've looked at the reliability indices. The second step for me is to just analyze the visual field for damage or a visual field defect, specifically for our patient's now glaucomatous loss. And so on the top left map where the arrow is pointing, you see the threshold values. These are measured in decibels, and this is really the raw data, the raw decibel stimulus that this patient is able to see. 36 is very commonly the max that you're going to see, right in that foveal region for most patients. And then the threshold values gets translated just to the right of that to the grayscale map. This is, in my opinion, really a patient education map, but the darker the gray or black is in that area leads or equals to less sensitivity of the stimuli that that patient is able to appreciate. And so be careful making clinical decisions off the grayscale map, but it can help for patient education. Total deviation and standard deviation for the pattern deviation plot is really where I should go when we're looking for glaucomatous visual field loss. And so let's define those. Total deviation is the deviation from an age-matched normative database that our patient has at each stimuli point. And so the deviation from normal. Pattern deviation is the deviation that our patient has from an age-matched normative database, but it removes the distractors that can make a visual field look worse, like uncorrected refractive error, pupil size, or media lens opacities. And so pattern deviation and standard deviation will often look the same, but not always. And then arguably the most important spot for me when I'm looking at a glaucomatous visual field is the pattern deviation probability plot. This shows the statistical significance of each spot that a patient missed. And so a p value of less than 1% means there's a less than 1% chance that this patient missed this defect or has this defect by chance alone. I also think this is a really good spot to look at the shape of visual field loss as we get into talking about characteristic visual field patterns in glaucoma patients. Looking to the right of the scan, we see some different values and some different terminology here. First, the glaucoma hemifield test. This is proprietary to Zeiss, but we know that glaucoma tends to affect superior or inferior optic nerve first. And so we tend to see asymmetric disease, superior and inferior. You'll tend to see that on visual field as well. And so what glaucoma hemifield test does is it compares mirror image clusters of points above and below the midline. And then it gives us the results of outside normal limits, borderline, or within normal limits. The mean deviation here, this is a weighted average of values in the total deviation plot. And so when we're looking at the mean deviation, this is going to be measured in decibels, and it's going to be a negative number. The higher the negative value, the more visual field loss a patient has. Visual field index, or VFI, this is really an enhancement of the mean deviation, and I think of it real simply as a percentage score. 0 would be total blackness, 100 would be a perfect visual field. And so 0, no visual field or total black, 100, no visual field defect there. And then that's a great area to educate patients as well. We'll talk about how we use VFI in trend-based analysis. And then pattern standard deviation, this is summarizing or giving us a quantitative value of visual field loss, but it removes the distractors of uncorrected refractive error, pupil size, medial lens opacities, this is going to be a positive number. The higher the positive number is for pattern standard deviation, the more moderate to severe the visual field defect is. And so now let's review some of the most common visual field defects that you're going to see in glaucoma patients. First, a paracentral scotoma. This is more central visual field loss, and this is shallow or partial damage to the neuroretinal rim. And so on OCT here, we expect to see mild retinal nerve fiber layer damage. We expect to see more central retinal nerve or ganglion cell damage as well to get this paracentral scotoma defect. An arcuate defect or a Bajerum scotoma, this often connects to the blind spot. And so you can see on that picture to the left how our visual field loss connects to the blind spot, and it's very commonly going to encircle fixation. An arcuate defect is going to respect the horizontal midline in many cases. And so on OCT for this patient with an inferior arcuate defect, we would expect to see a pretty dense superior retinal nerve fiber layer and ganglion cell loss. A nasal step defect, remember that we said on a visual field printout, we expect to see our blind spot about 15 degrees temporal to fixation. So we know that a nasal step is going to have loss opposite of the blind spot. Nasal step is also, and again, going to most commonly respect the horizontal midline, so above or below, which we see here for this visual field defect. And so for this patient, I would expect to see an inferior temporal retinal nerve fiber layer thinning. Less common primary glaucomatous visual field defects, but you'll still see them in your practice. On the left, you see a temporal wedge defect. This is visual field loss that branches off the blind spot. This correlates to more superior nasal and inferior nasal neuroretinal rim damage. Superior nasal is going to be most common to get a temporal wedge, but you can see it with inferior nasal as well. And then on the right, we see an altitudinal defect. This is a total superior or inferior hemianopsia. And so a total cut, either superior or inferior for this altitudinal defect. And if you see this on a baseline visual field, first time you're seeing this patient, I'm thinking much more ischemic optic neuropathy like an NAION or an AION. But if you have a patient with progressing advanced glaucoma, commonly you can see arcuate defects that progress to altitudinal defects. And so this doesn't only correspond to neurologic defects. You can see a progressing arcuate go to an altitudinal defect as well. How do we stage glaucoma severity by visual field? I think this is really important here. We're going to cover two different visual field criteria for staging. We'll look at the American Glaucoma Society or AGS and AAO ophthalmology preferred practice guidelines. And we'll also look at HODAP Parrish Anderson. So two different criteria for grading visual fields. First, here is AGS AAO preferred practice guidelines. And if you're thinking in your mind, why do I need to remember or know this? Well, I think three keys. Number one, it helps set our eye pressure target. It sets our treatment target for patients. Number two, for me, it helps set the follow-up schedule. When do I need to see this patient back? And number three, it's uber important for billing and coding. And so this is going to be in your ICD-10 codes of what severity of disease you have. And we all, of course, want to get reimbursed for the work that we're doing. And so AGS, AAO preferred practice guidelines on the far left, we see mild. Mild visual field loss has to have optic nerve head abnormalities consistent with glaucoma, and then no threshold visual field loss, but you can have screening visual field loss. I'm going to let that just sink in for a second. That means according to the American Glaucoma Society, mild glaucoma doesn't have visual field loss. Moderate visual field loss, according to AGS AAO, optic nerve head abnormalities consistent with glaucoma. And then you can have glaucoma visual field loss within one hemifield, but no visual field loss within 5 degrees of fixation. And then finally, severe, again, optic nerve head abnormalities consistent with glaucoma, and then visual field loss in both hemifields and/or visual field loss within 5 degrees of fixation. I think this is very digestible here. This is one snapshot slide that you can print, have in your office, and help for grading visual fields for severity. I kind of use a hybrid of AGS-AO and Hodap-Parrish-Anderson. With HPA, I really just use the mean deviations. So mean deviation of 0 to -6 decibels is going to be mild glaucoma. Mean deviation of -6 to -12, moderate, and -12 decibels or above being severe visual field loss. But according to the book, you must meet all three criteria to stay in mild. So mean deviation less than -6 decibels, and then a pattern deviation plot less than 14 points are depressed below 5%, and fewer than half of those points are depressed below the 1% level. None of the central 4 points has a sensitivity of less than 15 decibels. Moderate, mean deviation -6 to -12, with a pattern deviation plot 14 to 28 points are below the 5%, and 8 to 16 are below the 1% level of significance. Again, you see that at the bottom with the shaded boxes, and one central point measures less than 15 decibels. Severe glaucoma, mean deviations greater than -12, any one central point at 0 decibels, and both hemifields in the central degrees are less than 15 decibels. So in that central 5 degrees, both hemifields have spots less than 15 decibels. And so after we diagnose glaucoma, we get our initial visual field. Now we've staged it. We said it's mild, moderate, or severe visual field loss. Then we have to do serial visual fields to determine what is progression. And so first, to determine what is progression on visual field, how many fields are needed? We have to erase the inherent variability. Patients definitely have good visual field days, bad days. There's a learning curve to visual fields. And so if you're using event-based analysis, we can detect worsening on visual fields with just 2 fields. We're looking for a big defect or big change here. But if you're looking for trend-based analysis, and we'll cover both of those, you need a minimum of 3 tests. Next, what is the gold standard for visual field progression? You can use the picture to the right. We don't know. There really isn't a standardized criteria for this is progressing, this is not, that you're going to see in one of the big journals. Here's a study on the bottom that proposes this, a negative rate of change of 1 decibel per year with a minimum of 2 tests per year. Rapid progression being 2 decibels of loss per year with a minimum of 6 tests per year. It's a lot of visual field tests on that second one. But what I use in practice is 1.5 decibels per year of loss or more. I consider progressing visual field loss. If we refer back to our landmark glaucoma studies, the collaborative normal tension glaucoma study, or CNTGS, used 10 decibels of loss or more at 2 points, was considered progressing visual field loss. Advanced Glaucoma Intervention Study, or AGIS, used a complex scoring system. Collaborative Initial Glaucoma Treatment Study, or CIGITS, helped develop visual field index, and EMGT used a scoring system as well. And so let's start with manual progression analysis. This is event-based analysis. We have to have bigger change here. We're not going to see a trend line with just 2 visual fields, but if I have just 2, here's what I like to do. With just a snapshot view, I like to look at the mean deviation and the pattern standard deviation quantitative values. And so find the mean deviation, find the pattern standard deviation. For this patient, mean deviation changed less than 0.5 decibel, but pattern standard deviation changed about 1 decibel in this same year. Next, I like to look at the pattern standard deviation probability map, just looking at the shape of the visual field loss. Definitely on the far right column here, we have more points at the 1% and 2% significance. And then finally, make sure structure matches function. We have to add up the puzzle in these patients. What's the eye pressure? What's the OCT? Where were we starting from a corneal hysteresis value? But if all those say, hey, this is still a little bit murky, if I'm looking at these 2 visual fields on an event-based analysis standpoint, I'm saying we have some mild progression for this patient. Becomes much easier with guided progression analysis, or GPA. This is proprietary to Zeiss. And there's really two parts with guided progression analysis, or GPA. Key here is you need 3 tests to assess. First, on the bottom, you have the probability maps. This is going to shade in these triangles of different amounts based on, have we seen this change or progression on 1, 2, or 3 consecutive visual field tests. And then in the middle, you can see this kind of slope line here. This is our visual field index regression analysis, or a slope line, basically a trend line of how the patient's doing. I really like this area for education for patients. It's easily digestible, but what we're looking at is visual field index. Remember, that's that percentage score from 0 to 100. What I tell patients is I'll actually use my pen and say, we want to keep this line as flat as possible. And then circled right below that, you can see the rate of progression. And that's where that minus 1.5 decibels or more with 2 tests in the same year becomes significant for me. But guided progression analysis will do this for you. On the bottom right, it gives us the GPA alert. This is going to tell us we have a stable visual field possible progression or definite progression for this patient. And so I think really the idea, the mentality is shifting in glaucoma from, is there going to be progression in this patient? Okay, we've made the diagnosis. Will this patient ever progress? I don't think that's how I think as much anymore. Rather, I'm thinking I've diagnosed this patient. Now, what is the rate of progression? How many years do I have to have very slow or non-progressing glaucoma to save visual field and ultimately visual acuity? And so that's how I'm kind of thinking of progression in patients. Now, so let's move to what's new in visual field testing. What are some of the shiny new objects? First, with the Humphrey Field Analyzer. On the left, you see the liquid lens. This is a trial lens that allows liquid pressure inside the lens well to change the curvature, ultimately changing the power of the built-in trial lens. And so if you don't have a liquid lens or you trained on a different device, you're very familiar with going to your trial lens kit, getting the patient's refraction, making sure you put in the accommodative add that they need, and then sliding the lenses into the lens well, making sure you line up the axis just perfectly if they have astigmatism. And so I think the liquid lens really has the ability to reduce the errors of myself or a technician putting in the trial lenses before a patient takes their visual field. And then on the right, something that we're very affectionate to in our practice is now C2Faster 24-2C. You can see in red, this adds 10 central points for macular or central visual field testing, hoping to, again, correlate to ganglion cells, more central visual field loss that's maybe happening earlier in glaucoma. We just didn't have a good way to always measure it. The key here is with a C2Faster 24-2C, even with adding these 10 central points, it's still a shorter test than a C2Fast. And so up to this point, we've spent a lot of time talking about tabletop visual fields. We've talked a lot about using the Humphrey Field Analyzer, which in our practice is still the gold standard. I think that's still the gold standard across many of your glaucoma clinical trials and FDA research as well. But as you know, in your practice, it's not always easy for patients. There can be mobility concerns. You really have to have a room that is positioned just for your visual field. You have to be able to control the luminance for many of these devices, and there's some beeping and some noises. Space can be an issue. And so if we think about some of the current potential problems, I don't think these are all problems because, again, we have multiple Humphrey Field Analyzers in our practice, but the visual field can be a bottleneck to clinic flow. In our practice, we have an oculoplastic surgeon and multiple optometrists and ophthalmologists doing glaucoma. And so adding a visual field on for a patient who we maybe weren't planning on doing it that day can sometimes be difficult. We have declining reimbursements. That's really across a lot of eye care and in medicine. Requires a dedicated room and lighting for many of these tests. And we have reduced patient comfort and positioning. And so potentially what virtual visual fields could try to solve is improved efficiency with multiple devices. I think many of these virtual reality headset visual fields are trying to put multiple tests or modalities into one device. And so maybe it does contrast sensitivity testing, maybe it does some patient education, maybe it does visual acuity, and we'll look at some of those applications, but trying to put multiple tests into one device. Virtual visual field solutions also allows potentially for home testing and telehealth. I think this could really be potentially the holy grail in monitoring glaucoma. If we could have patients do their visual field at home and get really reliable, repeatable results that translate to some of the tests that we use in our office. Many of these devices don't need a dedicated room or space. You don't have to control for lighting because they have a mask or kind of a rubber stop that goes around them. Automated tests, which can be easier on the patient. And then I think patient positioning is one of the big potential wins here. You see this gentleman on his beanbag. This is the happiest patient I've ever seen taking a visual field. I would love to see that in our practice because, again, patients aren't knocking on the door hoping to come in to take more visual fields. And so I think this is really one of the big buzz spots in diagnostics for glaucoma is portable, wearable, virtual reality, visual field headsets. These are just 3 options on the pictures you see to the left. There are many more options in this space. These are just 3 that I have chosen, have some experience with. On the top left, this is Hiru's device. I'm not sure this is commercially available still, but we've done some trials with this in our practice. On the top right, this is Radius XR. And on the bottom, you see Oley's platform. And we'll kind of talk through all 3. I think all of these kind of virtual reality headset visual fields would say that they're really hoping to have a better experience for patients as far as mobility goes, positioning goes. Some of them try to make it gamified. I think the gamified part can sometimes be a little confusing for our patients, but they're trying to have a similar duration of time, maybe shorter as well. You can see the printout to the right. All of these companies are really striving to have a very similar printout because physicians, practitioners are used to seeing a visual field printout that has the threshold values and the mean deviation and the grayscale. And so all of them are trying to basically copy that. And so first, we'll look at 2 of the different platforms here. First, Oley's and the virtual reality visual field platform. This is a wearable headset. You can see it in the middle picture and the left picture. The application runs through a smartphone or a tablet. Patients have both eyes open, which is unique to a lot of these virtual reality headset visual fields. It has a mask around it, which controls for luminance. Oley's has 3 main kind of platforms, the in-office one, which is a 24-2, 10-2, and suprathreshold test. The Visual H, which is their home model. Unfortunately, I don't have any experience with this. I am interested to see how this correlates or translates. And then on the far right, you have the Visual Acuity, which can do Landolt C testing. This was a study that was presented at the American Glaucoma Society meeting that compared visual versus Humphrey Field Analyzer on a mean deviation standard. And so what they found is this compared well. It doesn't compare perfectly in all scenarios, but in both glaucomatous and non-glaucomatous eyes, the mean deviation had a good correlation coefficient or R value. This is Oley's printout to the right. You can see kind of how that looks. It has the total deviation, the pattern deviation, again, trying to have a mimicking printout to what we're most commonly used to with Humphrey Field Analyzer. Radius XR, this is another headset option. To my knowledge, this is the smallest option, the lightest option for a headset visual field. You can see it can be done in any lighting condition. You can see how it kind of fits over like a pair of glasses for patients. The technician is running the test here, which I actually think is a benefit. There's some other platforms that try to have the patient kind of run it themselves. In our practice, we had some concerns with patients just being confused or getting lost in that process. And so it is nice to have a nurse with a tablet running this for the patient. Radius XR is also trying to bring in some patient education videos. And so in a practice like ours, in a practice like yours, we're always trying to have our wait times be more productive for patients. And so could we do some different education at the same time? Peripherics, this is another newer modality, hopefully coming to market. It's currently in clinical trials and it's not available at this time. But Peripherics is trying to have more perimetry at home for patients. And so this actually works through a computer or a laptop. If you have a built-in webcam in your laptop, or you have an external webcam that you hook up, as the patient, I've taken this visual field. You actually look directly at your webcam. That's your fixation point, and then it presents different stimuli and can kind of watch you as you do it. The goal here is really for patient screening at home and for monitoring. And then you have a portal where the patient and the doctor can access the results. Again, this is currently in clinical trials, not available yet. Melbourne Rapid Fields, this is an in-office or at-home iPad-based visual field system. This, again, hopefully has the potential to increase the number of visual fields that a patient takes. If we could have home monitoring, especially if you practice in maybe a more rural area, patient sees you in a more kind of spread out fashion, but you see their visual field at 3 months or 6 months or whatever standard you have that patient on. Melbourne Rapid Fields, similar in duration to a CETA standard test, a little over 5 minutes per eye, and they tried to have an analogous printout as well. The study to the right is in the Journal of Ophthalmology, comparing Humphrey Field Analyzer versus Melbourne Rapid Fields, 28 patients. And here was the keys. The mean deviation was significantly lower on Melbourne Rapid Fields compared to HFA, but pattern standard deviation was significantly higher on Melbourne Rapid Fields compared to HFA. And so the cutting out the distractors, the pupil size, maybe the refractive error just didn't correlate strongly. And so this was taken from the conclusion Melbourne Rapid Field may be questionable for early detection compared to other options. I think it's harder for managing glaucoma progression if you're not getting a good correlation to the test that you had that patient take in practice. And so if you don't have visual field in your practice currently, which is better, 1 or 2? What is the technology that's right for you and your practice? Well, on the top left, I think if you have one location, if you have a very detailed long-term glaucoma practice, if you're doing any type of clinical research, you want years of follow-up and the real benefit of guided progression analysis, then I think you want a Humphrey Field Analyzer, you want a tabletop visual field option. But if you're new to visual fields, I promise you something is better than not having anything. And so if you're adding a technology, it is definitely better than what you have now, if that is nothing. The cost of acquisition can be lower for some of these headset virtual reality visual fields. You, many cases, don't need a room. If you only have one kind of pre-testing diagnostic room, and if it doesn't fit on that table, you can't add it. This is an option for you and your practice. It's also portable, so you could take it to multiple offices if you go to multiple locations. And so I think both of them definitely have their advantages. We have currently, I think, 4 Humphrey Field Analyzers in our practice. We've demoed multiple of the virtual reality headset visual fields. And so let's close with some visual field pearls, kind of some take homes here. Performing perimetry allows us to assess the function of the optic nerve and then compare that back to structure. Neurologic defects are going to be bilateral once we get to the optic chiasm and more posterior. Retinal defects are monocular. Remember the importance of matching perimetry to nerve cupping. You can get false positives quite frequently on visual field, especially if it's a patient's first time. So make sure what you're seeing on visual field adds up to the picture. Wearable devices are starting to compare better and better to, again, in my opinion, the gold standard, which is HFA. And then visual fields are a must in glaucoma. I think in 2024, to manage glaucoma at a high level, you need a minimum of 4 things. You need to be able to look at the optic nerve with a magnifying or a 90 diopter superfield lens, whatever you prefer, a dilated view. You need to be able to analyze kind of cupping or damage to the neuroretinal rim. You need to be able to measure the interocular pressure. You need to have an OCT, and you need to have a visual field to do a good job of managing glaucoma in 2024. And that's really the minimum